Welcome to the deep dive. Today, we're tackling a really tough and specific complication of sickle cell disease.
Sickle cell ulcers.
That's right. We're going to dig deep into the chapter on sickle cell ulcers from Wound Care Essentials, Practice Principles, really try and give you a clear picture of what's going on here.
Yeah, our goal for you, the listener, is to really understand why these ulcers happen, how doctors spot them, and, what can actually be done about them. We want to shed some light on this because it is a complex health issue.
Absolutely.
Okay, so let's get right to it. Maybe we should start with the foundation. Sickle cell disease itself, it's a genetic condition, right? It's something you're born with that affects your hemoglobin.
Exactly. Your hemoglobin, the protein in red blood cells that carries oxygen, it's an inherited disorder.
Okay.
And it fundamentally changes the shape or potential shape of that hemoglobin. This was actually first described way back in 1910 by Dr. J.B. Herrick.
Wow, okay.
And what it boils down to, at a molecular level, is a tiny change, a mutation on the globin gene.
Just one small change. One small change. Instead of the usual glutamic acid amino acid, you end up with valine in this specific spot in the hemoglobin S protein.
That sounds almost insignificant, but clearly it isn't. What's the big deal with that swap?
Well, that seemingly small change has this huge domino effect. When this abnormal hemoglobin S gives up its oxygen, like when it reaches the tissues, it starts to stick together. It forms these long, rigid polymers.
Polymers, like chains.
Exactly, like long chains inside the red blood cell. Imagine maybe like cooked spaghetti tangling up. This causes the red blood cells to lose water, dehydrate, and become stiff and distorted. They take on that classic crescent or sickle shape.
Hence the name.
Precisely. And this process also damages their outer membranes, making them more fragile and sticky.
And I'm guessing those misshapen sticky cells don't flow through blood vessels very well?
Not at all. Their rigid shape and damaged surfaces mean they're just not flexible, like normal donut-shaped red blood cells. They tend to clump together and get stuck, especially in the smallest blood vessels, the capillaries.
Like a traffic jam.
A perfect analogy. A traffic jam in these tiny streets. And this blockage restricts blood flow downstream. That leads to ischemia, basically, a shortage of oxygen reaching the tissues those vessels are supposed to supply.
Okay, I see. And this condition, sickle cell disease, it primarily affects certain populations, right?
Yes, it's most common among Black individuals. We see higher prevalence in the U.S., Africa, and the Caribbean, areas historically linked to regions where malaria was common, actually. The trait offered some protection.
Interesting. And there are different forms.
Right, two main forms. There's the homozygous form, which is generally more severe. That's when someone inherits the abnormal gene from both parents. And then there's the heterozygous form, or sickle cell trait, where they inherit just one abnormal gene that's usually much less severe, often asymptomatic.
Got it. So focusing on the ulcers we're discussing today, who within the sickle cell population is most likely to develop them?
Well, the data really points towards individuals with that more severe homozygous form, the SS disease. They are at the highest risk. And interestingly, there's also a bit of a sex difference noted in some studies. Males over the age of 10 with sickle cell disease seem to have a slightly higher likelihood, maybe around 5% compared to females.
5%. It might not sound like a massive number on its own, but when you consider how many people live with sickle cell disease?
You're absolutely right. It adds up quickly. It represents a significant number of affected individuals. And actually, it's estimated that about 75%, three-quarters of patients over the age of 30 with sickle cell disease will experience one of these ulcers at some point.
75%. Wow, that's huge.
It is. And just to give some U.S.-specific numbers for context, sickle cell disease occurs in roughly 1 out of every 365 Black or African American births. It's less common, but still present in Hispanic Americans, about 1 in 16,300 births.
And the trait.
The sickle cell trait, having just one copy of the gene, is much more common. About 1 in 13 Black or African American babies are born with the trait.
That really does put the scale into perspective. Okay, so we've got the deformed cells, the blockages, the ischemia. How does that chain of events actually lead to an ulcer forming on the skin, typically on the leg?
It's a multi-step process, really. While the cells can carry oxygen initially, the trouble starts, as we said, when they release that oxygen. That's the trigger for the hemoglobin S to polymerize, making the cells stiff and sticky.
That stickiness just sounds like trouble waiting to happen in those tiny vessels.
It is. It increases the blood's viscosity, its thickness, and these sickled cells tend to clump together. This slows down blood flow, particularly in the very small veins just after the capillaries, the postcapillary venules.
Why those specifically?
Because blood flow is naturally slowest in these tiny venules, making them more prone to blockages. So you get these microclots forming, and critically, that leads to ischemia, again, reduced blood supply, reduced oxygen to the surrounding tissues.
And this isn't just a one-off event, is it? It sounds like a recurring problem.
Unfortunately, yes. Patients often go through these repeated cycles. You get periods of reduced blood flow, the ischemia, followed by periods when flow returns. We call that ischemia reperfusion injury.
Reperfusion injury. So getting blood flow back can cause damage too.
Paradoxically, yes. When oxygen rushes back into tissue that's been starved, it can trigger inflammation and the release of damaging molecules. So this repeated cycle of injury and inflammation becomes chronic in the affected tissues.
Wow.
Over time, this ongoing damage can wear down the tissue, make it fragile, and in severe cases elsewhere in the body, contribute to organ damage. Plus, remember, the body clears out these damaged sickle cells faster than normal, leading to chronic anemia. And some cells become irreversibly sickled, just always in that problematic shape.
Are there other factors besides the basic sickling and ischemia that make someone more prone to getting these ulcers?
Yes, definitely. Several contributing factors have been identified, having that homozygous SS disease the biggest one, but also any kind of trauma to the legs, even minor bumps. Infection is a big one. Severe anemia itself makes it harder to heal. Even warm temperatures have been suggested as a factor sometimes. And then there are other underlying health issues like problems with the veins, venous insufficiency, or increased risk factors for heart disease, high blood pressure in the lungs, known as pulmonary hypertension. Interestingly, having a lower body mass index, being underweight, also seems to be associated with a higher risk.
That's counterintuitive, maybe.
It is a bit, yeah. The reasons aren't fully clear.
And where do these ulcers typically show up? You mentioned the legs.
The most common location by far is around the ankles in the malleolar area. And even more specifically, the inner ankle bone, the medial malleolus, seems to be the most frequent spot.
Why there? Why the ankles? Is the circulation just worse there?
It seems to be particularly vulnerable. The microcirculation, those tiny blood vessels in the skin around the ankle, they take a real beating in sickle cell disease. There's chronic injury to the capillary walls. They can thicken, become more leaky, allowing fluid and inflammatory cells to seep out into the tissues. This contributes to chronic inflammation in the area, making the skin weaker, more susceptible to injury from minor trauma, and just less able to heal efficiently if it does get injured. Those ischemia reperfusion cycles we mentioned really hammer these small vessels.
Okay, and I think I read something about nitric oxide being involved too.
Yes, that's a really important piece of the puzzle that researchers are focusing on. Nitric oxide is a molecule that normally helps blood vessels relax and widen, improving blood flow.
Right.
But in sickle cell disease, especially when those fragile red blood cells break apart, that's called hemolysis, they release hemoglobin directly into the plasma, the liquid part of the blood.
Okay.
This free hemoglobin acts like a sponge, soaking up the available nitric oxide. So there's less nitric oxide around to do its job.
So the vessels don't relax as they should.
Exactly. They tend to constrict more easily, worsening the blood flow problems, increasing pain, and contributing to tissue breakdown. So a key protective molecule is essentially being neutralized by the disease process itself.
That's a vicious cycle. Okay, so let's say a doctor suspects a patient has a sickle cell ulcer. How do they actually diagnose it? What's the process?
A really careful and thorough evaluation is crucial. You need to get the diagnosis right, obviously, but also understand the whole picture to plan treatment. It always starts with the patient's medical history.
What kind of questions would they ask?
They'll ask about any previous ulcers, definitely. How long has this current one been there? How did it start? Was there a specific injury, even a small one? They'll ask about swelling in the legs, edema, any history of bone infections, osteomyelitis, and also about classic sickle cell symptoms. Those episodes of severe pain, often called crises in the abdomen or joints, any recurrent infections, a known history of anemia. Sometimes even asking about unexplained fevers is important.
Okay, history first, then the physical exam.
Absolutely. A full physical exam is key. Checking vital signs, especially looking for fever, which could signal infection. Listening to the heart and lungs is important because, unfortunately, heart problems and pulmonary hypertension can be more common and severe in sickle cell patients who develop these ulcers.
Right.
An abdominal exam might check for an enlarged liver or spleen changes. Looking for scars from previous ulcers gives clues. And then, of course, a very careful examination of the ulcer itself.
What are they looking for specifically on the ulcer?
They'll note the exact location, the size, length, width, maybe depth, and the characteristics. Is it on the ankle? That's most common, but they can occur elsewhere, front of the shin, top of the foot, Achilles area. Need to keep those less common sites in mind.
Hmm.
And critically, does the patient also have signs of venous insufficiency? That can sometimes muddy the waters diagnostically.
Okay. And looking right at the wound.
Yes, a detailed assessment. What does the base, the wound bed, look like? Is there healthy pink or red granulation tissue, which means it's trying to heal? Or is it covered in yellow or tan slough, which is dead tissue?
All right.
Any redness, warmth, or swelling around the ulcer suggesting cellulitis? What kind of drainage is coming from it? How much? What color? Any odor? And crucially, is the area tender or painful to touch?
And checking blood flow.
Always.
Hmm.
A vascular examination is essential. Feeling for the pulses in the feet, the dorsalis pedis and posterior tibial arteries. If those pulses are weak or absent, or if there's any doubt about circulation, more advanced tests might be needed.
Like what?
Non-invasive vascular studies like Doppler ultrasound can measure blood flow. In some rare cases, an arteriogram might be considered, that's more invasive. And there are ways to measure tissue oxygen levels directly at the skin surface, things like skin pulse oximetry, laser Doppler, or TCPO2 measurements. Often, these oxygen levels are found to be low in patients with active ulcers.
Makes sense given the ischemia. What about lab tests? Blood work?
Definitely. If sickle cell disease hasn't been diagnosed before and someone shows up with a non-healing ankle ulcer, labs are key. A complete blood count, CBC, looking for anemia, tests to see if red cells sickle under low oxygen, like a sickle prep test, and hemoglobin electrophoresis to identify the abnormal hemoglobin S.
Okay.
One important point, though, if someone's had a recent blood transfusion, it can temporarily mask the abnormal hemoglobin on electrophoresis. So, a hematologist referral might be needed then.
And for patients already known to have sickle cell disease?
For them, the standard labs when they have an ulcer usually include a CBC with differential, looking at white blood cell types, platelet count, and a reticulocyte count.
What's the reticulocyte count tell you?
It measures how many young red blood cells the bone marrow is producing. It's usually high in sickle cell disease as the body tries to compensate for the rapid destruction of sickled cells.
And do these labs show specific patterns in patients with ulcers?
Yes, studies have found some typical patterns. Patients with ulcers often have lower hemoglobin levels, more severe anemia compared to those without ulcers. They also tend to have higher levels of markers indicating red blood cell breakdown, like LDH, bilirubin, AST, alkaline phosphatase.
Okay.
Also, higher levels of uric acid, a marker called NT-proBNP, which relates to heart strain, higher reticulocyte counts, as we mentioned, and higher ferritin levels, which reflects iron stores but can also be an inflammatory marker.
High uric acid is that significant?
It's interesting, yes. Some research suggests high uric acid in sickle cell patients might be an indicator of ongoing microvascular problems and hemolysis, even separate from having an active ulcer.
Huh. And infection risk, you mentioned that. How are cultures used?
Because infection is a real concern, getting a wound culture is important, especially if the ulcer isn't healing or looks infected. If there's suspicion of a biofilm, that's a kind of slimy, protective layer bacteria can form.
Right, notoriously hard to treat.
Exactly. If a biofilm is suspected, it really needs to be physically removed. That might mean sharp debridement, using ultrasound energy, or special enzymatic ointments. Good topical care and dressings that promote the body's own cleanup, autolytic debridement, are also key. Sometimes an enzyme called collagenase is used after debridement to help keep the wound bed clean.
Okay. And what about deeper infections, like getting into the bone osteomyelitis?
That's a serious concern, especially for ulcers that are deep, very painful, or if the patient has systemic signs like fever or a high white blood cell count. People with sickle cell are particularly susceptible to bone infections caused by Salmonella bacteria, which is unusual otherwise.
So how do you check for that?
Imaging is needed. Plain x-rays often aren't very helpful early on, and chronic bone changes from sickle cell itself can make x-rays confusing. Routine bone scans can show inflammation, but it's hard to tell if it's bone infection or just inflammation from the nearby ulcer.
So what's better?
MRI is generally the preferred imaging method. It gives much better detail of the bone and soft tissues and is more accurate for diagnosing osteomyelitis.
Okay.
In really tricky cases, a bone biopsy taking a small sample of the bone for culture might be the only way to be certain, but that has its own risks, like potentially spreading infection. Also, if an ulcer just won't heal after, say, 3 months or looks atypical, a biopsy of the ulcer tissue itself is important to rule out any rare chance of skin cancer developing in a chronic wound.
That's important. Now, one thing that really stood out from the reading was the pain associated with these ulcers.
Oh, absolutely. It cannot be overstated. The pain can be excruciating, intense, debilitating. Patients might be genuinely fearful of having the ulcer examined or treated because it hurts so much.
Which must make treatment incredibly difficult.
Hugely difficult. If the pain isn't managed effectively, patients are far less likely to adhere to the treatment plan. Dressing changes become ordeals. It impacts everything. So pain assessment and management are not just secondary concerns, they are paramount.
Right.
Any procedure on the wound, even just cleaning or debridement, really needs to be done with some form of anesthesia.
What kind of options are there?
It ranges. Topical agents, creams, or ointments like xylocaine or EMLA cream applied directly to the skin can be very helpful for managing background pain and making dressing changes tolerable. They're often used regularly, several times a day.
EMLA cream, I've heard of that.
Yes, it's a mix of lidocaine and prilocaine. There's also emerging evidence for using topical opioids directly on the wound, which might provide good pain relief with fewer systemic side effects than oral opioids.
Interesting.
Of course, oral pain medications, including opioids, are often necessary. And for more extensive procedures, local anesthetic injections, regional nerve blocks, or even general anesthesia might be required. Pain management specialists often get involved.
Are there any caveats with those topical anesthetics?
Yes, a couple of important points. EMLA cream has been shown to have some antibacterial effects, so generally you wouldn't want to apply it right before taking a wound culture sample, as it might affect the results.
Okay, good to know.
In that situation, using a local injection of preservative-free lidocaine, maybe within about 2 hours of the biopsy, is often preferred. Preservative-free is key there.
Got it. Okay, let's shift gears to treatment then. The source material highlighted that actually treating these ulcers successfully can be a real challenge. Why is that?
It's true. Despite advances in wound care generally, it's somewhat striking how few large, high-quality clinical trials have specifically focused on the best ways to treat sickle cell ulcers. Much of the practice is based on general wound principles, case series, and expert opinion. There was an interesting observation, though, that prolonged bed rest often leads to healing.
Bed rest. Why would that help?
The thinking is it likely helps by reducing the pressure in the veins of the legs, relieving venous hypertension, which improves local circulation around the ankle. But obvious.
Not exactly a practical long-term solution for most people.
Exactly. Not feasible or desirable. So while it tells us something about the role of venous pressure, it's not the answer itself.
So what are the core principles guiding treatment then?
Well, the fundamental principles of good wound care definitely apply. You need to remove dead or infected tissue, that's debridement. You need to manage any infection. You need to ensure there's adequate blood circulation. And you need to maintain a moist wound environment to support healing.
Okay.
But for sickle cell ulcers specifically, you absolutely must add effective pain control to that list. It's non-negotiable for success.
Right. Debridement, removing dead tissue, sounds essential, but also potentially painful, going back to that point.
It can be, which is why anesthesia is so important. There are different methods. Sharp debridement uses scalpels or scissors, but there are less painful options too, like using enzymatic ointments that chemically break down the dead tissue, or even using sterile medicinal maggots.
Maggots? Really?
Yes, maggot debridement therapy can be very effective. The maggots selectively consume dead tissue and bacteria, leaving healthy tissue unharmed. Patient acceptance varies, as you might imagine.
I can imagine.
But it's a valid option. And as we discussed, checking for infection, assessing circulation, those are fundamental. And emphasizing moist wound healing is critical. We've really moved away from old methods like wet to dry dressings.
Why is that?
They can actually harm healing. When the dry gauze is pulled off, it can rip away healthy new cells along with the dead tissue, and it's often painful. Modern moisture-retentive dressings create a much better environment for healing. There are many types available.
Okay. What about medications applied directly to the wound, like antimicrobials?
Topical antimicrobials are used if there's a clinical suspicion of infection in the wound. Systemic antibiotics, pills, or IV, are generally reserved for when there are signs the infection is spreading beyond the ulcer itself, like advancing cellulitis, fever, or a high white count. Dressings containing silver or cadexim or iodine are often used initially to reduce the bacterial load in heavily contaminated or infected wounds. But there's a caution with silver. Once the bacterial burden seems controlled, it's usually best to switch to a non-silver dressing. Prolonged silver use might potentially be toxic to the cells needed for healing.
Right, a balancing act. The information also mentioned nutrition, which might not be the first thing people think of with a leg ulcer.
It's a really crucial and sometimes overlooked aspect. As we mentioned, patients with these ulcers often have a low BMI, they might be malnourished. Healing requires building blocks, protein, vitamins, minerals. So ensuring adequate nutrition is vital.
Any specifics?
Making sure protein intake is sufficient. Checking electrolyte levels. Some older, smaller studies suggested that oral zinc sulfate supplements might be beneficial, as zinc deficiency seems fairly common in this group, and zinc is important for wound healing. Needs more research, but it's something clinicians consider.
And the leg swelling, the edema, how does that fit into treatment?
Managing lower leg edema is really important. That excess fluid in the tissues physically gets in the way of healing it. It impairs delivery of oxygen and nutrients and removal of waste products. Plus, chronic swelling stretches the skin, making it more fragile.
So compression.
Yes, compression bandaging, carefully applied, is often a key part of the treatment plan to control that swelling, assuming the arterial circulation is adequate.
Okay. Now, I was quite interested in the mention of tissue-engineered skin or skin substitutes. How successful has that been?
They've shown some definite promise, yes. These are advanced dressings, sometimes derived from human or animal cells, designed to act like a scaffold for the patient's own skin cells to grow into.
Sounds high-tech.
It is. But success really hinges on preparing the wound bed properly first. You can't just slap it on any wound. It needs to be clean, debrided of dead tissue with infection controlled. The underlying wound environment needs to be optimized.
Makes sense.
Some clinicians even recommend pre-treating the wound bed for a couple of weeks before applying the skin substitute. They might use agents that modulate protease activity enzymes that can break down healing factors. Things like oral or topical doxycycline or special collagen-based dressings. The idea is to create a more receptive environment.
And does that help?
Early studies suggest it might improve the take rate of the skin substitute and overall healing. Anecdotally, some patients also report less pain and better cosmetic appearance of the scar afterwards.
What about traditional surgery? Skin grafts.
Surgical options like split-thickness skin grafts, taking thin layers of skin from elsewhere, or pinch grafts, tiny pieces of skin, are sometimes used especially for larger ulcers, but they often require hospitalization, anesthesia.
And the success rate.
Unfortunately, reports suggest the success rates aren't consistently high, and there's a significant risk of the ulcer recurring after grafting. More complex surgeries, like moving flaps of muscle or skin with their own blood supply, are sometimes tried for very large or difficult ulcers, but again, success isn't guaranteed. It's challenging.
It sounds it. Now, hydroxyurea, that's a standard treatment for sickle cell disease itself, right? I was really surprised to read it. Can sometimes cause leg ulcers.
It is a bit paradoxical, isn't it? Hydroxyurea is incredibly important for many patients. It increases fetal hemoglobin levels, which reduces sickling and crises, a cornerstone of therapy.
So how could it cause ulcers?
The exact mechanism isn't fully understood, but one theory is that it might interfere with angiogenesis, the formation of new blood vessels, which is critical for wound healing. So in some susceptible individuals, it might impair the skin's ability to repair itself, leading to ulcer formation.
So will you do that?
If a patient on hydroxyurea develops a leg ulcer suspected to be related to the drug, the usual recommendation is to stop the hydroxyurea, at least temporarily, to allow the ulcer to heal. And interestingly, those tissue-engineered skin products have shown particular promise in helping heal these hydroxyurea-induced ulcers.
Okay. Blood transfusions were also mentioned as a treatment for resistant ulcers. How does that work?
Yes, transfusion therapy is sometimes considered for ulcers that are just not responding to standard care. The goal is twofold. Partly to increase the overall oxygen carrying capacity by raising the hematocrit, but mainly to dilute the percentage of the patient's own sickle hemoglobin, HbS, by adding normal hemoglobin, HbA.
Trying to reduce the sickling tendency.
Exactly. The target is often to get the HbS level below a certain percentage, maybe 30%, and raise the total hemoglobin. Transfusions might be continued regularly until the ulcer heals, or perhaps for a maximum period like 6 months.
Are there downsides?
Yes, there are risks. Repeated transfusions can lead to patients developing antibodies to the transfused blood, making future transfusions difficult. And there's the risk of iron overload, as the body doesn't have a good way to get rid of excess iron from transfused red cells. That needs careful monitoring and sometimes treatment with iron chelators.
Right. It sounds like there are also newer, maybe more experimental approaches being investigated.
There are. Researchers are always looking for better options. One mentioned is intravenous arginine butyrate. It's thought to have multiple potential benefits, maybe affecting the abnormal hemoglobin. modulating the immune system, helping collagen synthesis, and improving the inflammatory environment in the wound. Still under investigation.
Any others?
A few others are sometimes mentioned, often considered experimental or needing more evidence specifically for sickle cell ulcers. Things like antoxifylline, a drug that might improve blood flow, a topical growth factor called mulgramostim or GM-CSF, negative pressure wound therapy, wound VAC, hyperbaric oxygen therapy, and even electromagnetic stimulation. More research is really needed for these in the specific context.
It feels like a lot of the newer research is trying to get at the underlying mechanisms more directly.
Absolutely. That's where a lot of excitement is. Developing strategies that target the specific pathophysiology of sickle cell ulcers. So looking at agents that might reduce red cell dehydration, things that stop the sickled cells from sticking to the blood vessel walls, compounds related to nitric oxide, which we talked about earlier, and antioxidants to combat the oxidative stress and inflammation.
That nitric oxide pathway seemed particularly key.
It really does. We know levels are often low in sickle cell patients, especially with ulcers or during crises. The hypothesis is strong. If you can boost nitric oxide locally in the ulcer tissue, you might improve blood flow, oxygen delivery, and promote healing, maybe even prevent ulcers.
So how are they trying to do that?
One approach being explored is using supplements like L-methylfolate, pyridoxal 5-phosphate, a form of B6, and methylcobalamin, a form of B12. These are involved in pathways that can potentially increase nitric oxide production in the small vessels.
Anti-success.
There are some promising case reports showing improved tissue oxygen levels, TCPO2, and ulcer healing with this combination. It's not large-scale trial data yet, but it's encouraging. Researchers are also looking into ways to deliver nitric oxide directly to the wound, topically, perhaps with gels or dressings, to target the effect and avoid systemic issues.
What about using immunoglobulins? How would they help?
The idea there is to target the inflammation and the stickiness problem. Intravenous immunoglobulins, IVIG, might help reduce inflammation and improve microcirculation by potentially inhibiting the recruitment and adhesion of neutrophils, those white blood cells that can contribute to vessel blockage. Some experimental work suggests IVG might even help reverse vasoocclusion acutely. Again, more research needed for ulcer treatment specifically.
And one more, synthetic heparin sulfate.
Yes. CPP-LAQ20 is the name mentioned. This is a synthetic molecule designed to mimic natural heparin sulfates, which play roles in tissue repair, but it's engineered to be resistant to being broken down in the inflammatory wound environment.
So it sticks around longer.
Potentially, yes. It's thought to help by reducing local inflammation and promoting angiogenesis, new blood vessel growth. It's being looked at particularly for those really refractory, non-healing ulcers. An interesting finding in early use was that some patients reported significant pain reduction relatively quickly, even before major healing was visible.
That's significant in itself. It really underscores the point, though, doesn't it? That treating the ulcer locally is important, but you also have to manage the underlying sickle cell disease.
Absolutely fundamental. If the patient has severe, uncontrolled anemia or a very high percentage of sickling hemoglobin, any local wound treatment is fighting an uphill battle. Optimizing the management of the systemic disease is critical for ulcer healing success.
Okay, so given all these challenges in treatment, prevention seems incredibly important. What's the advice for patients to try and avoid getting these ulcers in the first place?
Patient education is paramount. It's number one. People with sickle cell disease need to really understand the importance of meticulous skin care for their lower legs.
Like what specifically?
Keeping the skin well moisturized daily to prevent dryness and cracking, which can be entry points for infection or breakdown, and being extremely careful to avoid any trauma to the lower legs and ankles. That means wearing protective footwear, being cautious about bumping into things, even using insect repellent diligently to avoid bites that could become problematic wounds.
Little things can make a big difference.
They really can. And managing leg swelling is key because edema is a major precursor to ulcer development and especially recurrence. So using prescribed compression stockings or elastic wraps consistently is vital if they have swelling.
And if they do get a small cut or scrape?
Treat it aggressively and promptly. Clean it well, apply an appropriate dressing, and watch it closely. Don't ignore minor injuries, and seek medical attention quickly if something isn't healing as expected or looks infected. Early intervention is crucial.
What about the clinician's role in prevention?
Clinicians should make it a routine part of every single visit for a patient with sickle cell disease to carefully inspect their lower legs and feet. Every time, and to regularly review these preventative skincare and trauma avoidance measures with the patient. reinforce the importance.
Constant vigilance, really. Looking beyond day-to-day prevention, what about the ultimate goal, preventing ulcers by fixing the underlying disease?
That's the holy grail, of course, addressing the root genetic cause. Bone marrow or stem cell transplantation offers a potential cure for sickle cell disease. Historically, there were concerns about doing transplants in patients with active ulcers due to infection risk, but encouragingly, more recent reports show successful transplants are possible even in that situation.
That's great news.
And the other really exciting frontier is gene therapy. Treatments like lentiglobin, which aims to insert a functional copy of the beta-globin gene into the patient's own stem cells, have shown remarkable early results in clinical trials, effectively reversing the production of abnormal hemoglobin in some patients.
Wow.
If these therapies become more widely successful and accessible, they hold the potential to prevent not just the ulcers, but all the complications of sickle cell disease. That's the ultimate prevention strategy.
So just to kind of pull it all together, sickle cell ulcers are clearly this really intricate, tough complication stemming from an inherited blood disorder. Figuring them out requires a deep dive into the patient's history, a careful physical exam, sometimes specific labs and imaging. Managing that intense pain is just absolutely critical for any hope of successful treatment.
Couldn't agree more.
And the treatment itself is multifaceted. Good local wound care basics, yes, but also tackling infection, swelling, circulation issues, and maybe using advanced therapies, all while remembering the importance of managing the underlying sickle cell disease itself.
A truly integrated approach is needed.
And prevention, through diligent patient education and self-care, is vital. But the real long-term hope seems to lie in those game-changing therapies like stem cell transplant and gene therapy that address the fundamental cause.
Exactly right. It's a complex puzzle requiring understanding of the disease, careful diagnosis, unwavering attention to pain, and combining local and systemic strategies.
Now, here's where it gets really interesting for the future. As this research continues charging ahead, particularly in gene therapy and these targeted treatments we touched on, the whole landscape for managing sickle cell disease and devastating complications like these ulcers, well, it feels like it's rapidly evolving.
It really does feel like we're on the cusp of major changes.
So the question this deep dive leaves us with, for you the listener, is what does this progress suggest about the future of genetic medicine? How might it reshape our approach to not just sickle cell, but other chronic inherited conditions? Definitely something to think about. Thanks for joining us for this deep dive.